Hi, everybody. Thanks for joining us tonight on this cold. If you're in Westchester County, it's kind of cold and dreary evening this evening. My name's Brenda Moynihan, and I am the Director of Marketing and Outreach here at the Kensington Senior Living. Welcome to our event tonight, and this is Breakthroughs in Hip and Knee Replacement with Columbia University Medical Center. For those of you that don't know the Kensington, just want to give you some brief information. We're located in White Plains, and we are an enhanced assisted living. We have a full spectrum of clinical support, including caring for those with Alzheimer's and additional dementias. If you'd like some information about the Kensington, please feel free to call us at 914-390-0080. We'd be happy to give you some information about us and also help you out if you have a loved one with some clinical needs or dementia. There will be a Q&A at the end of the presentation, so we will have time. So please jot your questions down and hold off until the end. So please join me in welcoming our speaker for this evening, Dr. Nana Sarpong. Dr. Sarpong is a fellowship-trained orthopedic surgeon specializing in hip and knee reconstruction. He is skilled in minimally invasive techniques. His practice leverages advanced technologies, including computer-assisted navigation and robotics, and offers the latest evidence-based surgical and non-surgical treatment options. And that's really what we're going to get into tonight. Dr. Sarpong was raised in New York City and attended Brandeis University in Massachusetts on the Posse Foundation Leadership and Merit Scholarship, graduating magna cum laude. He received his MD and MBA degree from Tufts University School of Medicine, where he was inducted into the Alpha Omega Alpha Honor Society and received the Norma S. Stearns MD MBA Excellence in Leadership Award. Dr. Sarpong completed his orthopedic surgery residency at Columbia University Irving Medical Center, where he was elected as executive chief resident in his final year. As a chief resident, he was the recipient of the NONS AFTECHR Award for Excellence in Adult Reconstruction and the Chief Resident Teacher of the Year Award. Dr. Sarpong completed the prestigious Adult Reconstruction and Joint Replacement Surgery Fellowship at the Hospital for Special Surgery, Weill Cornell Medical Center, where he received specialized training in navigation and computer-assisted joint replacement and complex and revision reconstruction. Welcome, Dr. Sarpong. And folks, I can tell you, yesterday we kind of went over some stuff with Dr. Sarpong. There's going to be a lot of really great information. So sit back, grab your whoopee, grab a hot coffee, and please enjoy the presentation.
Thanks, Brenda, for the kind introduction. Thanks, Gina, for having me. Let me just pull up my slides here.
Sure. And while you do that, I'm just going to stop my video and mute myself, and I'll just hand it over to you.
Awesome. Are you able to see my screen okay?
Yes. Yep, we see the screen.
Awesome. So good evening, everyone. Thanks for joining in on this webinar today, talking about breakthroughs in hip and knee replacements in 2023. So I'm currently a joint replacement surgeon at Columbia University Medical Center, New York Presbyterian in New York. I think Brenda will leave my contact information if any questions, and hopefully we'll have some time at the end to go over some questions. So we'll jump right into it. Brenda already sort of gave me an introduction here, but just a quick, grew up in New York, medical school in Boston at Tufts, Columbia for residency. I served in my last year as chief resident. I went on to HSS, do my fellowship in joint replacement surgery, where I had specialized training in robotics, computer navigation, and complex primary and revision surgery. So here's a brief overview of the things that we're going to be talking about today. We'll start off by discussing what exactly arthritis is. We'll review some of the non-surgical treatment options for arthritis. And then we'll talk about minimally invasive surgery. What exactly does that mean? And we will end on the technology that's currently available in 2023. And then again, leave some time for questions at the end. So jumping right into it, what is osteoarthritis, also known as arthritis? And so this is a common disorder caused by loss of cartilage that affects the joints, be it the hip, the knee, the shoulder, ankle, hands, wrist. The focus of this talk tonight will just be on the hip and knees, as I'm a joint replacement surgeon, hip and knee surgeon. Generally, this ailment progresses and often results in pain, deformity, and patients complaining of stiffness. It can have a huge impact on quality of life and activity level. In general, it affects about 27 million people in the US alone, about half of which are over the age of 75 years old. There are several various courses of osteoarthritis, arthritis, and sometimes this could be due to obesity. As you can imagine, the heavier set you are, the more forces go across your hip and your knees. And so, that leads to earlier wear and tear of the joints and earlier cartilage loss. Genetics can have a lot to do with it as well. So you might have, a mother or father or grandmother, grandfather that had arthritis and passed off the genes to you. Any trauma to your hip or knee region can lead to early cartilage loss and result in early, what we call post-traumatic arthritis. Instability of the joint, be it the hip or the knee, can also cause arthritis. As you can imagine, when the joint is unstable, you get early cartilage wear and leads to early arthritis. And again, with age, as any joint wear and tear, once we lose the cartilage that God gave us, there's no way to get it back, unfortunately. And so how do we know if we have arthritis? Generally, patients will complain of pain related to activity, be it walking, navigating stairs. Patients often complain of pain going up and down stairs. As the disease advances, you may feel pain at rest, just sitting there or standing there, and sometimes even at nighttime, waking you up from your sleep. Furthermore, sometimes patients can get stiffness and their joints might start to get deformed. And so, for example, in the knee joint, some patients might get bowing of their legs, or their legs look bow-legged, or sometimes even knock-kneed. In some individuals, it progresses slowly and can be managed for multiple years without surgery. However, in some other patients, their arthritis can progress very fast and can result in early need for surgery in the form of a joint replacement surgery, which we'll talk about. And so on the hip arthritis side, what exactly are the symptoms? Stiffness is the most common, as well as pain, and pain is usually in the groin. Patients will often complain of difficulty bending over, donning their shoes, or, getting up from a low chair or a low car. I have a little schematic here that you guys can take a look at, where you see that in a healthy hip, in a non-arthritic hip, there's this pink cartilage tissue, which basically serves a purpose to provide a cushion between a hip ball, which is here, and then the acetabulum, also known as the socket. When you develop hip arthritis, unfortunately, the cartilage starts to thin out and gets damaged. And so what happens is bone starts to rub on bone, the ball starts to rub into the socket, and that's what causes the pain from arthritis. Here's another schematic here. You see when you've lost joint space, you've lost your cartilage, it results in narrow joint space, you lose cartilage, and then over time, the bone starts to react and form bone spurs. How do you diagnose hip arthritis? With x-rays. And so you could see here, this is an x-ray of a normal right hip. You see the normal joint space right here. Space is good. This is the thigh bone, also known as the femur, and this is the acetabulum, also known as your hip socket. When you develop hip arthritis, unfortunately, like I said in the last slide, you lose all the cartilage. And so as a result, your thigh bone, the femur, starts to erode into your socket, the acetabulum, and you get all these cardinal signs of arthritis here. So joint space gets narrowed from the cartilage loss. You develop bone spurs over time. You can see a bone spur right here at the bottom of the socket. Over time, if the arthritis progresses quite a bit, you can actually start to lose bone On the thigh bone part, the femoral part, or the socket part, you can see bone loss. And then when at its worst, you can actually start to form cysts within the bone, be it the femur or the acetabulum. On the knee arthritis side, very similar, patients complain of stiffness, and so they are unable to bend your knee completely. They have difficulty with kneeling and going up and down stairs. The knee is especially stiff and painful when walking. Patients will often complain of clicking and popping around their knee. And as I said a couple of minutes ago, sometimes when it progresses really, really bad, they could see that their knee starts to become deformed. Some patients get a bow-legged appearance, and then some patients a knock-kneed appearance. Bow-legged, we call it varus, and then a knock-kneed valgus. You can see here this blue schematic. Blue is actually cartilage. In a normal knee, you have good cartilage, both on your thigh bone part, your femur, and then your shin bone, your tibia at the ends of it. You also have soft tissue known as menisci in between, which function as shock absorbers, essentially, to prevent your cartilage from getting damaged. As you develop arthritis, you lose all the cartilage. You can see the blue is lost now, and it's turning into yellow, which is bone. Bone starts to rub on bone, you get cartilage loss, and with time, you get bone spurs, joint space narrowing, and again, cysts, just like we saw on the hip side. How do you diagnose knee arthritis? Again, x-rays are usually the mainstay form of diagnosis, and your orthopedic surgeon or your primary care doctor will usually start off by ordering an x-ray for you. On the left here, you can see this is an x-ray of a normal knee. Again, the black is good. That means that you've got good cartilage and good menisci in between. This is the outside of your knee, also known as the lateral compartment. This is the inside of your knee, also known as the medial compartment. And with time, when arthritis kicks in, you lose all that black, all that good joint space and cartilage, and bone starts to rub on bone. With time, it forms a reaction, and you can see the ends of the bone turning white here, known as subchondral sclerosis. You could also see bone spurs forming as a reaction to losing cartilage and the arthritis process kicking in. You can see it here on the lateral compartment on the outside of your knee as well. And so now we can get into the different treatments for arthritis. And this, is a huge spectrum, and we always go from the least invasive, so non-surgical treatment options. And once you've exhausted all of those options, then I think it's totally reasonable to pursue, surgical intervention. But I think it's especially important to always begin with the least invasive, and then move on to invasive. And so non-surgical treatment options, again, aimed at treating your symptoms. It doesn't cure. Again, once you've lost the cartilage that God gave you, there's no way to redevelop it, unfortunately. And so the treatment options that we have in 2023 aim to treat your symptoms. It's not a cure by any means, outside of a joint replacement surgery, which we'll get into. And so what are these different treatment modalities? The first is physical therapy and exercise, which I'll get into in detail. We'll also go over weight loss and activity modification. We'll go over the different medications that are available. Non-steroidal anti-inflammatory medicines like Aleve, Motrin, Advil. And then sometimes your doctor can also prescribe you prescription strength non-steroidals like meloxicam, or some people call that Mobic or Celebrex or Voltaren. And then, there's also Tylenol. Racing is also a totally reasonable option that we often offer patients. And then injections are also very helpful for patients, steroids or gel injections, which we'll get into. So physical therapy and exercises, what exactly does this mean? You're working with a trainer or physical therapist to help increase your range of motion as well as your flexibility. Patients will benefit from this because it strengthens muscles around the hip joint as well as the knee joint. And the hip joint really strengthens your core muscles around the knee, your hamstring muscles, and your quadriceps muscles, which can be very effective in reducing pain and improving your function. Unfortunately, it's a catch-22 when your disease process of arthritis is so bad. You can imagine that doing physical therapy can actually cause you pain. At which point we tell patients probably is a good time to consider, the next step, which we'll get into, which would be in a form of, surgical intervention. So weight loss and activity modification. You put about 3 to 5 times your body weight through your hips and your knees when you're walking and when you're getting up from a seated position. And so you can imagine that every pound of weight that you lose, for example, losing 10 pounds can result in about 50 pounds decrease of pressure across your hips and your knees. So we'll often suggest in heavier set patients that losing weight can really, really be helpful in, helping them treat their symptoms of arthritis. So back to the medications, again, it ranges from over-the-counter medicines that you can just pick up from your drugstore, your local drugstores. This is Tylenol, ibuprofen, whether that's Motrin, Aleve, Advil, and then, the prescription strength non-steroidal medicines that I talked about. So we've got Mobic or meloxicam, Celebrex, and then diclofenac or Voltaren, which your physician can prescribe for you. These are all helpful in controlling the pain, inflammation, and stiffness. What I would say about this is for the non-steroidal anti-inflammatories, make sure you're taking it with food and not on an empty stomach to avoid you getting ulcers and, stomach bleeds from taking too much of this. For injections, comes in 2 forms. Steroid injections, also known as corticosteroid injections, as well as gel injections, which I'm sure many of you have heard of. For the steroid injections or the cortisone injections, this can provide pain relief and reduces inflammation. It's good for swelling, not so much for range of motion. And it's pretty variable on how long it works for. For some patients, it can last up to 6 months, but unfortunately, for some patients, it can last just a day or 2, especially when your disease process of arthritis is way advanced. Steroid injections and or gel injections don't help as much when you've lost all the cartilage and there's not much space and you've got bone and bone rubbing each other. The viscosupplementation, also known as gel injections, like the hyaluronic acid, basically functions as a lubricant. It's generally better when you've got earlier stage or middle stage arthritis. When you've got end-stage arthritis, is not as helpful as I just alluded to when you don't have enough space. These are often injected in a series of 3. And so you come 1 week at a time. Basically, you spread it out in 3 weeks, 1 week at a time. And again, just like the steroids, it's pretty variable how effective these are, especially when your arthritis is pretty advanced. And so once you've exhausted all the treatment options that I just discussed, I think it's totally reasonable to consider surgery and to consult with a joint replacement surgeon. You want to go to a person who's well-trained, who feels very comfortable, who has a lot of experience with hip and knee replacements. And so when to consider surgery, again, when you've failed and you've, unfortunately, all the other treatment options are proven to be ineffective for you. You're no longer able to do the things that you want, need, or enjoy doing because of pain. And so you can't walk your dog, you can't go up and down stairs, it's waking you up from night, you can't work anymore. I think at that point, it's totally reasonable to have a frank discussion, share decision-making with your family, with yourself, and your surgeon. And I think preoperative education is very important to set expectations early on and see what your goals are before and during and after the whole process of surgery. And so we'll start off by discussing minimally invasive total hip replacement. Hip replacement has been around for a long time as one of the most successful operations in modern medicine. In fact, it was cited in the Lancet, which is one of our most cited journals in medicine, as the operation of the century, the total hip replacement. It offers pain relief, improved function after surgery, increased quality of life, and has really shown economical benefits that far outweighs the costs. It's been shown to be reproducible and reliable. And so what does a contemporary total hip look like in 2023? The hip replacement consists of a femoral component, which is implanted into your thigh bone or your femur, and an acetabulum component, which goes into your socket. And in between is a plastic liner. And you could see here, this is all in one piece that allows your hip joint to function, to bend and rotate like a normal hip. And you could see here a schematic here showing it. And this is what it looks like after surgery on an X-ray. In my practice in 2023, there are two different ways that I perform hip replacements. There's a direct anterior approach, which, the layperson might call it from the front, and then the mini posterior approach, which some people call from the side. And basically, I decide on which approach to use depending on the patient's body habitus and what their weight is and your body mass index. The incision for minimally invasive surgery is generally a small incision, so 3 to 4 inches for both approaches. When I do it from the front, I use x-rays to help guide me and put in the hip replacement in a perfect position to allow your hip to function like a normal hip and for it to last for a long time. When I do it from the side, I use a robot to help me navigate it and to help me get the prosthesis in the exact place that I'm planning to have it. And we get a CT scan before surgery to help you plan for this. Generally, again, this is usually selected for patients that are heavier set, as it's a lot easier. This here is a picture of what the approach looks like in the operating room here for the anterior approach or the front. And then generally you're laying on your side in the operating room, and again, from the posterior approach. And so what are some of the frequently asked questions about hip replacement surgery? Patients will often ask, will they need general anesthesia? And, I'll say no. Generally, we use a spinal or epidural with very, very light sedation. It just makes your recovery a lot easier. It reduces nausea, vomiting, urinary retention, reduces the amount of narcotics you take after surgery, and allows you to be up and walking almost immediately after surgery. The surgery itself takes about an hour and a half, whether I'm doing it from the anterior approach or the posterior approach. Patients will often ask how long they'll be in the hospital. In 2023, the healthier patients will tend to go home the same day of surgery. In fact, they're walking on their brand new hip replacement immediately, just an hour or so after surgery. And so pain's well controlled and they're able to go home just a few hours of surgery. Most other patients will stay in the hospital at least one night, the sicker and the frail patients. Patients will often state after hip replacement surgery that the pain is way, way improved, even just one day after surgery compared to before surgery. After hip replacement surgery, patients are expected to walk with a cane or assisted device or roll-in walker or a cane for approximately a week or two after surgery. Most patients are able to participate in the majority of the daily activities at 6 weeks after surgery. For hip replacements, range of motion hasn't really been an issue because a hip joint is such a forgiving joint. And so physical therapy is not as important, but it helps you regain your strength and function back after surgery. And so for the more frail patients, we'll often offer them that. By about 3 months after surgery, most patients after hip replacement surgery have returned to all normal activities without any restrictions. You can expect to return to driving at about 2 to 4 weeks after hip replacement surgery. If it's your right hip for an automatic transmission car, generally 3 weeks once you're off narcotics. For a left hip, we usually say 2 weeks once you're off narcotics. If you're working from home, in the pandemic world that we live in now, most patients can expect to go back to work if you're working from home and you've got a sedentary job at about 2 to 4 weeks. If you've got a more demanding job, you work at a warehouse, or you're picking, lifting things, I think those patients tend to go back to work at 2 to 3 months. But again, by about 3 months, most patients have fully functioned without restrictions. And again, patients often forget which hip was actually replaced because they're doing so well. And then lastly, how long will your hip replacement last? The current data in 2023 actually suggests an annual failure rate of just under 0.5%. And so that means that, most patients are outliving their hip replacement. And so, the hips will not need to be revised at all, or their knees, which I'll show you shortly, that these implants last a very, very long time, 20, 30, 40 years now. For knee replacement, also a life-changing operation, again, gives you pain relief, improves function, increases quality of life, has incredible economical benefits that far outweighs costs, It's been shown to be reproducible and reliable. What does a total knee replacement in 2023 look like? Again, I showed you a previous schematic of what worn out cartilage looks like. And here you could see that the bone is sort of reacted to all the lost cartilage. And so the knee replacement essentially resurfaces the ends of the bone with metal. On your thigh bone here, you've got a metal prosthesis here. And then again, on the shin bone, your tibia, also a metal. And in between is a plastic polyethylene liner that allows the knee to function like a normal joint. We still keep all the ligaments and tendons around your knee. We don't take any of that out. So your knee is able to function like a normal knee. And this is what it looks like on x-rays afterwards. You might have heard of what we call partial knee or uni compartmental knee replacements, which just means that, you replaced only one part of the knee. I like to think of the knee as a 3-room household. So you've got the outside of your knee, inside of your knee, and then the kneecap area. And for some patients, their arthritis is only affected one portion of their knee. And so this example here is just on the inside of the knee. And so we have an operation that can tackle just that without affecting the other compartments, the other rooms of the home. And so here's an example of a medial inside of the knee being replaced, where the outside or lateral compartments, as well as the kneecap area, is left alone because it was not osteoarthritic, it wasn't arthritic at all. What does minimally invasive total knee replacement look like in 2023? Again, the incision is usually quite small, about 4 inches. This is what the scar will look like after surgery. We barely see it, barely make it out. Patients do very well. What are some of the frequently asked questions about knee replacements? Again, just like hips, most patients will not need any general anesthesia. We often will use regional anesthesia, so spinal or epidural, and very, very light sedation to make your recovery a lot easier. Just like the hips, you're walking almost immediately after surgery with your brand new knee replacements. The surgery, again, takes about an hour and a half. Most patients are going home the same day. But if you don't go home the same day, you're usually in a hospital for a night or two. Patients can be expected to walk with a cane or a walker for approximately 1 to 2 weeks after surgery, just like the hips. Unlike the hips, knees require a little bit more handholding and physical therapy for about 6 weeks after surgery to achieve excellent knee range of motion and to regain your strength. But thankfully, around 6 weeks, you are able to walk almost normally without a cane or a walker. And some will have some mild pain, but about 3 months or so, most people, about 90%, will have achieved full recovery. Just like the hips, for a right knee, you can expect to be driving around 3 to 4 weeks if you're off narcotics, and around 2 to 3 weeks for the left knee for an automatic transmission. For a manual transmission, if you're using both your feet, it tends to be longer. Similar to the hips, if you're working from home, generally 3 to 6 weeks off of work. And then if you've got a more demanding job, again, about 3 months before you can return to work after a knee replacement. Very similar survivorship as far as the implant longevity and the survivorship of the implants. And so here are some quick examples of the technology that I use in my operating room in 2023. So here's an example of a knee replacement computer-assisted navigation that helps surgeons get the alignment of the knee as well as the soft tissue balance just right to allow your knee to function just like a normal knee and for the implants to last a long time. This here is a robot that I use for the posterior hip or the approach from the side. And basically the robot is able to help you put the implant in the exact same position that you planned for before surgery, even before you walk into the operating room, so that there's no second guessing and your implants are exactly where you plan to put them in. Here are just some small examples of this is what the robot looks like here, and this is what the screen for the robot looks like in the operating room. When I do the anterior or the front hip replacements, I use x-rays. So here's an example of an x-ray machine that I use intraoperatively or during surgery to confirm that, the hip replacement is being put in the exact same place that we intend to put it in. And so I would like to end this webinar, at least my portion, before the questions come in, on whether or not joint replacement surgery, whether that's a hip replacement or knee replacement, is it really worth it? As I had mentioned before, it's been dubbed the operation of the century by the Lancet. There's really no other surgical intervention or medical intervention outside of cataract surgery that really improves quality of life and returns patients back to the function like joint replacements does. Your general health and sense of well-being is significantly improved, especially for patients who have really, really debilitating symptoms before surgery. And I think here is a testament that 9 out of 10 people say that they would have definitely had the same surgery again to treat their arthritis, just because they do so well. It's an operation that works so well, and patients are able to achieve the function and go back to the life that they yearn to go back to. And so I will end there with questions. Hopefully you guys came with some questions. Make this interactive.
Dr. Sarpong, I mean, this is so fascinating. If people who are watching, if they're old enough, if you recall 30, 40 years ago, having these surgeries was so much longer than an hour to an hour and a half. That blows me away, that it's only an hour to an hour and a half. Unbelievable, right?
We've made strides, yeah. And
amazing, and that you could go home the same day. Again, when I think even back 10 years ago, there was no way you're going home the same day, right?
Yeah.
Right.
Yeah, patients were staying in a hospital for weeks.
Absolutely.
And then we went to days, 3-4 days, and now the same day, just hours after surgery, you're walking on and you're going home.
And if I remember years ago, they didn't want you to move, right? They wanted you to be stationary. Now, I guess they found that's really not a good thing. They want you up and moving.
Yep, exactly, because we fear that the patients will get deconditioned. And so, just getting used to your brand new joint replacement.
Right. Amazing.
And patients do very, very well.
It up to questions. If you'd like to ask the doctor any questions, please type it in. In the meantime, while we're waiting, I have 2 questions. So the first is, you talked about all those things to do before you get to this point, right? And we talked about inflammation. Is there anything out there like, I've heard sour cherry juice, for example, helps to reduce inflammation. Have you heard about anything like that, or any of the natural things?
Yeah. What I would say to that, Brenda, is absolutely, the sort of homemade stuff, if it helps you, I would say go for it. If it's an anti-inflammatory, like ginseng or garlic, I've heard some patients say, if it provides you anti-inflammatory relief, I would say absolutely go for it. It has as long as it doesn't have a side effect with other medicines that you're taking, I would say absolutely.
Okay. And I have another question.
I've heard of cherry tart being a really, really good anti-inflammatory as well.
Yeah. Cool. You're talking about with the hip replacement and the femoral stem. Is there anything about body rejection? I mean, should people be worried about any of that?
That's a fantastic question, Brenda. The metals that we're using for hip replacement and knee replacement are relatively inert. The overwhelming majority of people, I would say 99.9% of people, don't have an allergy to titanium or cobalt chrome. Some patients will have a nickel allergy. Those patients we will often know beforehand because they had a reaction to something else. Those patients will usually get a hypoallergenic implant. But for the overwhelming majority of people, even if they have a nickel allergy, the body just doesn't react as it would react if you were wearing, a necklace once it's inside your bone.
That's interesting. Okay, we have a couple of questions. Let me just take a look here. What is the expectation regarding pain in post-hip or knee surgery? Good question.
Fantastic question, Miriam. So you're going to be in some pain after surgery, just from the incision. But as I had mentioned, I will separate out hips and knees just to be, realistic and fully transparent. Hip replacements are less painful than knee replacements. And so oftentimes patients are not even taking any narcotics, any opiates at all after hip replacement surgery. A lot of our patients will take it maybe for the night of surgery or the night after, and then totally just take Tylenol and ibuprofen afterwards, or an anti-inflammatory. For knee replacement surgery, it tends to be a little bit more painful. And so patients are generally taking pain medicines for about a week or just over a week. But again, when you compare it to the pain that the patients were usually having before surgery, it's night and day. Especially after hip replacement surgery, the pain is almost immediately gone when they wake up, from surgery. And that's the groin pain that they were having from hip pain, from the hip arthritis.
Ask you something, because this is one of my questions. If we're talking about hip replacement, do you ever do both at the same time too?
Yes, for someone who does not have a lot of medical comorbidities and they can tolerate surgery, and so that would be 2.5, 3 hours of surgery. Because as I had said, each surgery is about an hour and a half. If you're relatively healthy, we do that sometimes. It's the benefits of that is that you're under one anesthetic, so just one and done. You don't have to come back. You don't have to go under anesthesia twice, even though it's just a spinal or epidural anesthesia.
Wow.
And we do that for the younger patient. For the more elderly, frail patients, I don't think it's worth it. Right. We would stage in, that's generally within 3 months. And so we'll do one side and then come back at 3 months later and do the other side.
Okay. We have another question. Any precautions with the hip replacement with your two approaches?
Fantastic question. So from the anterior approach, from the front, no precautions at all. From the posterior approach, not really, I call it modified precautions. I don't want the patient basically bending their knee and bending their hip and rotating and bringing the hip inside at the same time. Otherwise, you can do whatever you want.
Okay.
And that precaution for the posterior side is usually just for 6 weeks after surgery.
Okay.
And that's just to prevent the hip from coming out of the socket, the prosthetic hip from coming out of the socket.
How do you know when you actually need knee surgery? I have had cortisone shots over the past couple of years, and physically active and lost more than 20 pounds during this time. I feel relatively okay, but know that I have knee osteoarthritis, which acts up periodically.
Yeah, thanks for the question, Felicia. I would say that if it's just intermittent pain, like you're describing, it's not every single day, it's not chronic, then you don't need a knee replacement surgery. I think once it becomes debilitating, you can't do the things that you enjoy doing. It's hard to get up from a seated position. It's hard to navigate stairs, going up and down stairs. It's waking you up at night, or you're having trouble sleeping at night. I think at that point, then, it's okay to actually consider a knee replacement surgery.
And on the same line of what our attendee just asked, the cortisone shots, how many shots is enough? And then, you're thinking about going to the next step, you've had too many. Is there any
Fantastic question. Yeah. So cortisone shots in my practice, I'll generally give a patient 3 tries of cortisone shots, and I'll spread it 3 months apart. And so give you an injection today. I can't give you another injection until 3 months from now. And then the next one, another 3 months from then. Also, we have literature that shows that if you get an injection within 3 months of surgery, there's a high risk of infection. And so if I give you an injection, you have to wait at least 3 months before you can have any surgery around your hip or your knee. Otherwise, there's a risk of infection.
Wow.
But yeah, to your point, Brenda, you don't want to give too many injections because, the steroid can over time start to affect other soft tissues around the knee. If you've lost arthritis, especially when the arthritis is so bad, there's no bone. Oftentimes it's, injections aren't helpful at all. And I'll be frank with patients and say, this is sort of just a Band-Aid. It might give you relief for a day, 2, maybe a week, but you really need, and then you're prolonging it because you've got to wait 3 months until knee replacement. But yeah, generally 3 months apart.
Another question, should I do physical therapy prior to hip or knee replacement? That's a good question.
Yeah, I think for knee replacement is more important because we know that your knee range of motion before surgery dictates your post-operative knee range of motion. And so We actually call it prehabilitation, so pre-surgery rehabilitation. And so working on your knee, your quadriceps, and your hamstring strength before surgery will definitely have a positive impact after surgery. And so I would totally, I would endorse that, and I'd totally recommend doing that, especially if your knee is really, really stiff. On the hip side, not so much. I mean, if you think it's going to help you stay strong and help you recover, oftentimes the hips do so well anyway, that we find that it's a waste of time, and, you know, patients can sort of just save their PT sessions for after surgery.
Do you see a lot of leg length discrepancies after hip and knee replacement?
So 20 years ago, we did. Whoever asked that question, fantastic
Yeah.
question. Yeah, but with the anterior approach, as well as the robotic and computer assisted technologies that we're using, we're getting real-time feedback. And so from the front, when the patient's lying on your back, I've got both legs, you know, draped, and I can feel their legs before they leave the operating room. So they're not going to have a leg length discrepancy. When I'm using a robot, when I'm doing it from the side, same thing. The robot is telling me what their leg length was before and after surgery. And so we'll never leave the operating room until your leg length is perfect.
I have actually a question for either the hip or the knee replacement, you know, except for, I guess, age and comorbidities. Is there ever a time when it wouldn't be a good thing to have these things?
Yeah, I mean, I would say, I mean, yeah, the sickest of the sick patients should not have, if the risk of surgery is really, really high, then it's not worth it, right? We can find other ways like controlling your pain. But otherwise, I think if you want to get back to your, you know, your activity and you're healthy enough to have surgery, there's no real contraindication.
And now I have another question. So, you know, you talked about the longevity of the hip and knee replacement. If somebody gets a hip replacement at 50 and it lasts 20, 30 years, could they then get another after that?
Well, yeah, we haven't studied it past 30 years, but we're beginning this, you know, start to study, and especially with the newer generation implants, it's lasted them 40, 50 years. And so we're doing operations on people with congenital hip problems. Like the other week, I operated on a 23-year-old. You know, that implant that I put in there is going to last probably 50, 60 years. But to your point, Brenda, yes, there's always a higher risk when the patient is younger that they're going to need, you know, a redo, because the plastic liner has worn out. But back in the day, the plastic liners were wearing out, you know, 10 years from when it was put in. Now it's lasting 40, 50, 60 years. We haven't studied it that far out, but it's not lasting 10 years like it used to. It's
Not
lasting
like in
way.
the past.
Yeah.
Folks, any more questions? We do still have time. Do you have some more time, folks? So type in your questions.
Really good questions are being asked.
Yeah. I like the question about the leg length discrepancy. I do know someone who probably about 10, 15 years ago had a hip replacement, and her leg, the length of her leg changed.
Mm-hmm.
So interesting. Well, it doesn't look like we have any more questions. So I'm going to wrap it up. First, Dr. Sarpong, I want to thank you so much. Fabulous presentation. I mean, there's a lot of really good information, and I'm very visual, so I really like those photos. I hope the attendees like them also. I also want to thank my colleague, Gina. Gina, folks, you don't see Gina, but she runs the back end of all of my events. Thank you, Gina. And I want to tell everyone, if you stay until the very end, we're going to put up a slide. It will have contact information for Dr. Sarpong. And probably by about Monday, I'll send an email to everyone, again, reinforcing contact information for the doctor if you'd like to get in touch with him. And also, if you'd like to get in touch with the Kensington, again, you could always call us. We'd be happy to give you information. So wait, I think we do have one more question. Let me just check. Yeah, we do. Okay, so Virginia's saying, very informative and easy to understand presentation. Thank you. And I have a question from Sue. She says, why is the knee more painful than the hip? Good question.
Fantastic question, Sue. If I had the answer, or if you had the answer to that, you would be probably a billionaire. We don't know, 10 to 15% of patients who undergo knee replacement for whatever reason are dissatisfied from pain. And, we don't know why. I think that number is decreasing with, the advent of computer-assisted navigation and robotic technology. But I think that the knee joint itself that we're born with is less forgiving than the hip joint. The hip joint is so much more forgiving. There's so much variability around the knee, I think, is why the knee is such a painful. And you're making, frankly, more bone cuts, and it's more surgery around the knee with a knee replacement than the hip, is what I would have to say. Because I think, like I said before, that the knee joint is a three-room household. You've got the patellofemoral joint, which is your kneecap area. You've got your shin bone and your thigh bone. So theoretically and hypothetically, that because it's more surgery around, especially in a total knee replacement, that's probably why it's a little bit more painful.
Okay, great. So folks, I guess that's it. Again, I want to thank everybody for joining us tonight. Hope you all enjoy the rest of your evening. Again, Dr. Sarpong, thank you so much for all this wonderful information. Thanks, folks. Hold on and you'll see the information how to contact the doctor. Thank you.
My pleasure, guys. Thank you so much.